Okay, first of all, I'm going to take up with that whole depressing thing. Yes, it's a bad problem, and the overall 5-year survival for lung cancer is around 16, 18%, somewhere in that range. And that's a big problem. But where you have a big problem, you have a huge room for improvement. If you start with a disease that's only 1% fatal, it's going to be hard to make an improvement and say, wow, we've changed some things. So if you start with a big problem, you have opportunities to make a change. And so, yes, it is depressing when you look at the past. But when you think about the future, there's big opportunities. And then when you do have somebody that's a tough case, where you get them through it, and they need surgery, and then they need chemo and radiation to get through it all, and they've survived, that means a whole lot more because they've fought a tougher battle in my mind. So I don't think it's depressing. I think it's more challenging and in some ways more rewarding. But I don't know, that's just me.
It's pretty optimistic.
Yeah. You got to be an optimist to work in lung cancer. If you're a pessimist, you not belong in here.
As medical oncologists, we are frequently asked, how can we handle this? How can we not be depressed by not only lung cancer results? I mean, I can quote you worse results in lung cancer, in pancreas or melanoma or brain tumor. So it's not really only lung cancer. And my answer is generally, and I really truly believe in this, is that the last thing the patient needs is somebody to be emotional. They're coming to you for your expertise, to help them, to guide them, not to say, oh, I'm sorry, because they don't know you actually. So they really need somebody to be actually detached to some degree and not to be depressed. That's number one. Number two, I would argue, I always give this example to my residents when they come to interview, that when a person has chest pain and we give them nitroglycerin and the pain goes away, and if we felt like heroes, we are really stupid, because this is almost common knowledge. I mean, what kind of energy did you spend to know that the chest pain needs nitroglycerin? It's almost not a medical knowledge anymore. So what really matters, if professionally speaking, is not really the amplitude of benefit. That is what people before you discovered and got, they can be happy about that. The one who discovered the nitroglycerin, I will applaud him for a week. But the point is, once you know about it, it now is no longer an issue. Same thing you could argue, the cardiologist who puts a balloon in the coronary artery and blows the balloon, and now, wow, the pain is gone. Now, who is really to be credited? I would say the engineer who gave you that balloon, not really the person who is doing it, because now it's a common thing. So my point then is, what should make me happy or not happy, depressed or not depressed, is really, number one, can I achieve what is achievable? Because if I cannot, there's a problem with me, number one. So can I deliver what people say is deliverable? And number two, can I contribute? Can I make it better? Can I make it advance or figure it out? Because that's what we are really supposed to do. Not just do what can be done, but really push it. And if that is the goal, then oncology should be extremely exciting. And I'm really extremely excited, as you probably can tell. And I've never felt bored or depressed. The issue is not getting depressed, and it's not the irrationalization and not an attempt to protect myself because I don't want to feel sad. It's because I realize, plus there's a lot of, I don't know what the right term is, but I mean, if you don't know about that patient who's dying, are you really doing a good job? I mean, you're just separating yourself. You're just not looking. It is happening. People are having the problem. They are already having the bad outcome. So when you go to another specialty, what did you do? You really escaped. You didn't necessarily. So in many ways, you could say you should be even proud of yourself as oncologist, because you stood up to the difficult challenge. It's not attractive. It's not necessarily glamorous to say, I'm going to treat melanoma or I'm going to treat the lung cancer, because the results are small or the benefits are small. But the problem is, the patients currently want this benefit even when it's small, so it's my duty to deliver it. And number two, the field needs improvement, so they need input from us, from clues that we may get, understanding of biology, so that we can put it together in a proposal for improvement. And that is very exciting. That's not depressing at all. In fact, I would always argue it's exactly the opposite.
Yeah, one of the things is that, of course, many cancers are discovered rather late, and they tend to be difficult to treat because of that. And I think some of the big advances that we're going to be making is going to be in early detection and also prevention. So how do you prevent cancers is a big thing. There's a big new push towards this now. Understanding how they actually start, why they start, is going to be a really important thing, because obviously if we can prevent them, then we've got the cure. And trying to cure them when they're very advanced is extremely difficult to do. So there's a lot of research going on now about cancer prevention. And I think that's really where we're going to make the big advances, not in curing advanced cancer so much. With lung cancer, as we've seen, there's been very little improvement in that over the last 15, 20 years or more. But understanding how the whole thing starts and how to prevent it, and certainly not smoking is going to be very important there.
Dr. Safar, if they prevent the cancers, will you then be depressed? No. No? Okay.